we've got a fair number of people online, and I'm sure there'll be more joining as we go. So I'd like to welcome everyone to this morning's webinar on managing mental health in people with Down syndrome. My name's Darryl Steff, and I'm the CEO here at Down Syndrome Queensland, and I have the pleasure in being joined by Isabel Bowden, who is our Community Support Officer at Down Syndrome Queensland, and our guest presenter, Dr Cathy Franklin, who's a Senior Research Fellow and Psychiatrist. I'd like to start this morning by doing an acknowledgement of country. So in the spirit of reconciliation, Down Syndrome Queensland acknowledges the traditional custodians of the country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So before we get into the webinar, just a couple of introductions and housekeeping. As I said, I'm the CEO here at Down Syndrome Queensland. I'm joined by Isabel Bowden from our support services team. I guess our roles here at Down Syndrome Queensland is we're often the first line of support or where people call and contact us if they're having concerns, challenges or questions around things such as mental health, but we actually offer supports for the whole lifespan of people with Down syndrome and their carers and supporters. And the main thing we're here to do is support people with Down syndrome and their support networks to be able to achieve what they want to in life. We have a huge number of different services and supports that we offer, and I do encourage you, if you haven't reached out to us recently or if you're not aware of the full range of services that we offer, please take the time to have a look at our website or just get in contact with us. A couple of housekeeping things. So questions, we have got everyone on mute, and we will keep it that way. Can I please request that questions are put in the chat, which you should be able to find generally at the bottom of your screen, I think. Please put questions in there. We will keep an eye on them as the webinar goes, but unless there's anything that needs addressing immediately, we will hold the questions until the end of the webinar, and then we will put those questions to Dr. Cathy, hopefully getting through as many of them as we do in the time we have available. One of the reasons for holding questions to the end is that we are recording this webinar, and we obviously want to make sure that if people are asking questions that are private or start disclosing things of a personal nature, that they don't get included on the recording. So I appreciate your support in that. So why are we here today? Well, we wanted to hold a session for our members around mental health for people with Down syndrome. It's an area we do get a lot of inquiries about, and we know that often it can be difficult to discuss openly. We understand that for people who have an intellectual disability, there is a very strong likelihood of experiencing mental health issues at some point in adulthood. It's actually about 2 or 3 times greater than for the rest of the population. And there's a range of reasons for this. And no doubt Cathy will be talking to us about some of those as we go through her presentation. And as for anyone experiencing mental health issues, early detection and intervention is key to ensuring that the right supports are provided by the right people and at the right time. So a big part of bringing everyone together today and holding this webinar today is to hear from Dr. Cathy Franklin, whose work and research specialises in this area. And we want to make sure that when families or carers notice changes in the individual with Down syndrome, they're equipped with some knowledge to ask the right questions when they're supporting that person so that they can hopefully get the assistance that they need. We hope that families and carers who attend this session will feel empowered to seek those opinions, ask those questions, particularly if they feel the individual isn't getting the support they need, or if they've got doubts about what support is being offered or provided to that individual. So without further ado, I'd like to introduce our guest presenter for today. Welcome to Dr. Cathy Franklin. Dr. Cathy Franklin is a psychiatrist who specialises in intellectual and developmental disability in adults. Cathy's the inaugural director of the MATA Intellectual Disability and Autism Service, known as MIDAS, which is a statewide clinical service established in 2018 that works to improve the health and mental health of adults with intellectual or developmental disability. Cathy's also recently become the director of QSID, the Queensland Centre for Intellectual and Development Disability, and her research interests include the areas of health services, research, and the biological underpinnings of conditions occurring in this population. She's the chief investigator on several projects, including the iCards, which is the investigation of catatonia and acute regression in Down syndrome study, and also the Easy Health, which is enhancing access to services for your health project. Cathy's presented at several different national and international conferences and meetings. She served on the committee of the RAND's CP section of Psychiatry and Intellectual Disability for over 10 years, is the chair of the Queensland branch of that section, and also serves as the vice president of the Australian Association of Developmental Disability Medicine. In 2020, Cathy was awarded the Mater Research Sister Regis Dunn Award for outstanding contribution to research relative to opportunity. And Cathy has a firm commitment to improving mental health and quality of life for adults with intellectual disability through her research and clinical practice. So really pleased to have Cathy with us today. Welcome, Cathy.
Thank you. I will get on to, thank you for that lovely introduction, Daryl, which helps me because I feel like I don't need to introduce much of myself now, so that's good. I will, if it's okay, I will go to share my screen and get that started from the beginning. Let me know if that's not the right way around, but I think it should be. So I guess, so I think the one thing I wanted to say when we start off today is that I wanted to talk about mental health, which does include mental health problems and treatment and things, but mental health broadly, I think, is a very important issue. Certainly we work with people aged 16 and over, so you will hear that probably coming through in the way that I talk if you have young children. But I hope that today really will help equip people with the knowledge that they need to help identify when things are going wrong and to help understand what's happening. And often there's a real need to make a representation to medical people that may not know much about people with Down syndrome. So hopefully this presentation will help with all of those. Before I get started, I'll quickly just tell you a little bit about our clinical service. This picture here is a picture of my lovely team. This includes the MIDAS team and the QSID team all together. I'm not in the picture because I'm taking the photo. And I think Ritwika, one of our researchers, is hiding behind someone else. But essentially, we're based at the Mater Hospital, South Brisbane. We have a clinical service under MIDAS. And if you Google MIDAS and intellectual disability, it will come up with a web page if anyone's looking for how to refer or who we see. We also have a phone number that you can call to make inquiries with. I will put up my contact details at the end of the presentation. We are a small team and it looks like a lot of people there, but most people there are part-time. A couple are work more than that. We have in that photo, we've got our clinical staff, which includes psychiatrists, a general practitioner, some trainees, including a rehab medicine registrar and 2 psychiatry registrars. We also have our program lead, Kathy Beck, who helps me run the whole thing. She's an occupational therapist, has an occupational therapy background. We also have a psychologist and a private psychology service. We are funded by Queensland Health Mental Health Branch, but that funding doesn't stretch too far, so that's why our psychology service is private. We also have a nurse and a wonderful admin officer called Dell. Our research staff include Katie Brooker, our postdoctoral research fellow. We have some research assistants, and you can see one of those in the front right, dressed in the red, is Katrin, our research assistant, who also has Down syndrome. We've been able to employ Katrin as part of the Easy Health project that's funded by the federal government. The only other thing to say about me specifically is that I do have a particular interest in Down syndrome that actually I've been working in this area since 2004, which is becoming a long time now. And I've worked at QSID since 2006. I saw my first patient with Down syndrome and regression in 2009, and so became kind of more interested in that area, which was really quite a mystery, and it's really kind of picking up traction now. So I'm a member of the Down Syndrome Medical Interest Group in the United States, and usually attend their clinical meetings in person annually, which I held along with the American Down Syndrome Association meetings. That last year was virtual and this year is virtual again. I also had the pleasure of going to the World Down Syndrome Congress in Glasgow. That's me with my sister there. And that's to remind me that to mention that my sister has a son with Down syndrome. He's quite young. He was born congenitally deaf and has cochlear implants. And so if anyone knows of anyone who's supporting someone with Down syndrome and cochlear implants, let me know, because it's really rare. I also put those things up because going to those websites, there's a lot of really good information, not most recently about COVID, but there's a lot of health information and a lot of links, particularly the Down Syndrome Medical Interest Group information. And if you ever get the chance to register or attend, or virtually attend maybe in these days, one of the World Down Syndrome Congresses, they have a really good program, and I've found them really, really good to attend. So today I'm going to keep the pace up, because this is all the stuff I want to cover. What I want to cover first is a brief thought about what actually is mental health, and then I want to talk about the broader context, and that includes talking about what in medical terms we call it the behavioural phenotype, but really it's what's normal for Down syndrome. And I'll talk about that, then move on to talk about some of the neurodevelopmental disorders that are more common in Down syndrome, so autism and ADHD, a bit about dementia, very quickly about medical issues to think about, and then I'm going to move on to how common mental health problems present. Despite the title of the talk, you won't see me talking a lot about management in this talk, and there's a really good reason for that, and the reason is that to get the right management, you really need to get the right diagnosis. So if there are any health practitioners listening, I know that they always want to know, tell me about the management, tell me about that, but you need to get the diagnosis right first. And that's always what I emphasize, because if you are going down the wrong path there, you're not going to switch to the right path. The management is reasonably straightforward, but getting the diagnosis right in people with Down syndrome can be tricky, and you really need to have a good sense of what is normal for Down syndrome and what things can occur and how they look when they do occur. So that's really what I'm working on emphasizing today. So before we start, I just wanted to point out, this is the World Health Organization's definition of what mental health is. And the big message from this is that mental health is not just not being sick. Mental health is about being a state of well-being where each person can realise their potential, where they can participate in the community and work productively and cope with life. So you can see that that definition is much bigger than just not being sick. But that's a really good thing to guide us as we're thinking about what problems can crop up, because this is our goal. This is where we want to have everybody ideally sitting. So that's an important thing to remember. As we move on to the broader context, well, I've called it the broader context, I'll be talking about what's normal and the behaviour and some of the other things. I want to first, before I talk today, doctors, and I'm a doctor, all of medicine is based on patterns and putting patterns together, and whether there's test results or not, putting patterns together and recognising the patterns. So medical people particularly are primed to look for patterns and expect to see patterns. But really, if you look at the real world in any sense, there's a lot of variation, and it's the same in Down syndrome. So although a lot of people like to think that everyone with Down syndrome is, you know, singing and dancing and outgoing and engaging, and I know that you might know that, but we have some families coming to clinic and saying, look, my person is not like that. They're not like the ones on TV. And I have to say that I don't see very many people who are like the people on TV with Down syndrome. So the real world is different. And I've got that the picture of the person sunbaking, because, you know, people overseas think all Australians are tanned and on the beach all the time, and you can probably see I'm not tanned, and I never tan. I've got very white skin, and that's easier to tell you in person when you can see all of me. So now I want to get on to talking about the behavioural phenotype of Down syndrome is in the academic literature what it's called, but really it's just what we count as normal for Down syndrome. And that's a really important concept, because the problem we have in clinical practice is that a lot of health professionals don't know what's normal for Down syndrome, and they can be way too inclusive. So we can have people who are very sick going along to see a doctor and go, oh, it's just their Down syndrome. So, oh no, that's, you know, seeing things that aren't there, that's just their Down syndrome. So it's really important to know, because it's a pretty well defined pattern for the sorts of things that are more common in Down syndrome, and you will see some of these features will ring true for everybody listening who knows someone with Down syndrome. The picture of the book there, that's the 2021 edition of Dennis Maguire and Brian Chicoine's book on mental wellness in adults with Down syndrome. And that's an excellent book. If you only get one book in this area, get that one. It's on Booktopia and online websites. I've got the previous edition, but that's an excellent book. And particularly this talk through what's normal in Down syndrome, they've got a really great way of going through all of what's normal, but also of talking about, you know, what problems arise and what you can do about that. And I think that book is helpful for families, but I also recommend it to health professionals and trainees to have a look at, because I think they've done a really good job of explaining these things. And both Brian Chicoine is a general practitioner who runs a Down syndrome clinic in the States, and if you Google his name, they've got lots of resources on their website. Dennis Maguire is a psychologist who's been out to Australia previously with Down Syndrome Association and given talks on this topic. So this little bit, I have to say, is very much modelled on their talks and their information, because I find it a really helpful model. And I should go back and just say the headings I've got that I'll be covering are around concrete thinking, taking time, the strengths and weaknesses of language for people with Down syndrome, self-talk, because that's a big issue when we're thinking about mental health, problems of getting stuck, and memory. So I'm going to go through each of those. The first is around concrete thinking, and that might seem a funny thing to come up first, but it's one of those things that when you think about it, you will see there. And with a lot of these aspects, what I've got an adaptive column, because all of these things that are common in Down syndrome, there are some good things about them, and there are some things that they can that can make life more challenging. So I don't know about my column headings, but that's what I'm trying to do with these slides. So concrete thinking, what is concrete thinking? It's not understanding the abstract meaning behind a statement, and people don't think about it a lot of the time, but it's interpreting things literally. You see that also in autistic people. But concrete thinking can really help people to be very practical and grounded, and to focus on what's important now rather than theoretical other problems in the future, or seeing things in bigger contexts, or all of those things that happen when you start to think more abstractly, particularly about problems. Of course, concrete thinking can get people into trouble. It can make it more challenging to communicate with somebody if they have trouble thinking more abstractly. It can make it harder for people to be more flexible, but also to understand why they're doing something. So if you're able to understand the bigger picture, then you know why you have to do the thing that you really don't like doing. But if you can't see that bigger picture, it makes it a lot harder and a lot less intuitive to do the thing that you really don't like doing, whether that's brushing your teeth or something more complex. It can also make it harder to generalize skills to a new setting. So someone might learn something in one setting, but not automatically be able to pick that up and use that same skill in another setting. So there are there are certainly advantages and disadvantages. Now, this one will probably have a lot of people nodding. And the way that Dennis and Brian talk about it in the book really is that there are two sorts of time for people with Down syndrome and sense of time. There's slow and slower. And that's totally okay if you don't need to be somewhere in a hurry. And actually taking more time to do things helps us have more time to enjoy things. It helps us to notice things more, to take more things in. And really, if you think about how hurried life is these days, that can be a really great thing. However, if you're rushing out the door to get to an appointment and you're supporting someone with Down syndrome who is not wanting or going to move that fast, it can drive everybody a little bit crazy. Now, the slow and slower, that can become really quite extreme. So there's a line where that becomes abnormal, and that condition of regression and catatonia and Down syndrome, it really crosses over into way too slow. In that condition, we have people taking like 4 hours to eat breakfast. That's not okay, but a general sense of needing to take more time. So when you're working with someone, you need to give them time to think about things, to answer things, and to do things. And really, they have their own sense of time. And rushing is very rarely helpful. A slow push towards a goal is going to be a lot more effective. If we're looking at language, now there is a variety of strengths and weaknesses for everyone with Down syndrome and how their language is going. But in very broad terms, for people with Down syndrome, their receptive language, so understanding what other people are saying, is usually much stronger and better than their ability to say what they're thinking. So this means that people are very good at hearing things and taking them in, and with a combination of things being quite emotionally intuitive, that can be helpful. And they can be quite sensitive to other people's issues. It can be difficult in a few ways. One that I probably haven't put down there, one of the real difficulties is other people don't think that if you've got poor expressive language, they assume you've got poor receptive language. So people think that people with Down syndrome haven't heard things or haven't picked things up. But if there is something going on in their family, they will know. Even if you've tried not to tell them, they will know. And it's the same in every workplace. And there is this tendency for people to try and talk in more complex language or to say things that they think the person won't understand. They will understand. So there's that to be aware of. The other area that runs into difficulty is really when you're wanting, it can be really hard for someone with Down syndrome to say what they're thinking and to get the words out. And that can be frustrating. We all want to feel like people are hearing us. And so that can cause problems there. Self-talk is an issue that I do get asked about. Self-talk is a lot more common in people with Down syndrome and in autistic people. So the first thing to say about self-talk is that when we use the word self-talk, we're talking about the inner speech that we're all having in our head, that we're thinking about things. We think through all sorts of things. It's just most people keep their thoughts in their head and don't say them as words. So a lot of self-talk is verbalizing what other people would keep in their head more. It's not all like that in Down syndrome, I have to say, because you will hear people repeating things that other people have said or movie scripts or things like that. But broadly, that's the best way of thinking about self-talk. It's people saying their thoughts or what's going through their head out loud. And there's a number of functions of self-talk and you know, there's the old saying, it's the first sign of insanity and things, but some of us do it more than others, and there are different reasons that people will do it too. For a large number of people, you know, sometimes it's out of boredom and a lack of being able to talk to other people. For other purposes, though, include processing what's been going on. So quite Sometimes it will be a company thing or those sorts of things, but other times it will be more stressful things or things that have been said that they still haven't made sense of. And so this tendency to talk out loud to yourself can be good. It can help you process things. It can improve your memory because it's a way of verbally repeating things so that you remember them. And it can be a benefit because you can rehearse things out loud. So what you're going to say. If you're nervous about something, you can talk through it. It can cause issues in public, but to be honest, often it's other people's problem, really, more than the person themselves. But some people can have issues with that. It can be mistaken for mental illness, and this is it can get quite complex territory when the things that someone is saying start to sound more paranoid or more odd. And so it can cross over into that. And under stress, it can, I don't know if grow into mental illness is the right way of putting it, but it can be the way that mental illness can present under stress. And I don't know if it's covered anywhere else, but for people in with Down syndrome broadly, they often have very vivid imaginations. And so where normal is and where abnormal begins is a grey zone, because people can have very active fantasy lives that can come out through their self-talk as well. I really tend to give a broad allowance for that. I do place the line where someone starts to act on those things is where we really need to be thinking about doing something. And that something depends. It might not be medication. It might be looking at what's happening or why it's happening like that. But just to flag, that can be a grey zone. Getting stuck is another thing. And there's actually a lot. This is the terminology that Dennis uses in their book to cover. Sometimes there's not great words around this, and some mental health words get misused generally. But this refers to the tendency to be stuck on the same track of thought, be stuck doing the same things, but things like hoarding also come under that. It doesn't, it's a little bit of a miscellaneous kind of miscellaneous thing, but you will know, if you know someone with Down syndrome, you will know that they can have the tendency to get stuck on the same topic or the same thing, and it can be difficult for them to move on, and sometimes they don't want to move on to another topic. Hoarding and collecting can also be quite common in Down syndrome. It can be quite common in the general community as well, but it's probably even more common in Down syndrome, and that can make it challenging living with someone. That's often something that you need to be aware of and to work with, and to try and prevent it turning into too awful a problem. But again, that's a thing too, where is the normal abnormal line is not always clear. This tendency to get stuck can, of course, be adaptive. It can help people stay on track when they're learning things. It can help them remember the same sequence of events, and they can lay down that memory and remember those things much better than someone who's going to shift onto something else. It's also good if you've got a hobby and you want to concentrate on that hobby or that interest. That can be helpful as well. People with Down syndrome, again, this is a generalization, but generally they have a very good visual and visuospatial memory. So the things you will hear and see are things like knowing where everything in their room is. If someone's moved something, they'll move it back. But it also means that they're able to remember things that they've seen in the past, people that they've seen, movies that they've seen, but it can kind of be a bit of a problem if it's not a good thing that you're remembering. So a good example is, if someone was going through the checkout at the supermarket and someone shouted at them for something, the way that their memory works is that they don't often their memory doesn't put that into the past. In the general population, where it's easier for us to file that in the past and move on. The person for Down syndrome, it's still like it's in the present. So they go back to that shop again, there's someone shouting at them again, there's no way they're going in that shop. So again, this excellent visual memory can be very helpful. It can help you remember directions if you see them. It can help you remember who people are, but it can also be a problem, and it can make it really difficult to move on. It can also be an issue for things like grief and processing grief, for which there are no rules, and no normal and no time frame, but it certainly can make it harder to move on. And often it takes longer for people to work through those things, and they're more sensitive to cues. One cue will bring the whole thing back again. And I'm sure probably a lot of people are nodding their heads around that. So look, I guess I wanted to, sometimes medical talks can all be very negative. I did want to just briefly reflect on the good things, right? So there's a lot of things that people with Down syndrome are often especially good at. Enjoying life is certainly one of them. Cheering up people around them is another thing. In the workplace, they can be very good at learning things and sticking to structure and be quite conscientious with things. So those are things to remember. So now we're going to step on to, I'm keeping an eye on the time, there's a couple of things that don't fall under mental illness, but I really wanted to cover today. So we're stepping outside of what we would call normal, but we're not yet stepping into mental illness. This is a little bit of a miscellaneous section, but I wanted to remind people because behavioural changes is often how people with Down syndrome will present with problems. So they're not going to say, I feel depressed or I feel sad. You might see it in their behaviour. And medical professionals particularly can have a tendency to go, oh, it's just behaviour, that's not medical. Go and see something else. So this slide is really just a reminder to say behaviour can have a lot of things behind it. People can be communicating a lot of things. The key concept I always try and get across to health professionals when I'm teaching them is that behaviour always has a meaning. So people will say, oh, they do it for no reason. That's really never true. There's always going to be a reason. It may not be very obvious. These are the common reasons. I won't read through them all, but you can see some of them are around pain. Some of them are around wanting more control over things. One of them is attention. And I always have to pause and say people get very negative about people who want attention, but we all actually want attention at some point. We just have different ways of commanding attention. I've got everybody's attention right now. And if I lived a life where no one was ever listening to me, I would want attention, and I would probably find some ways of getting it. So that's not it's not a bad thing. It's just meaning. I just wanted to have a quick word because autism isn't a mental illness. It's a pervasive developmental disorder, and it's something that is generally evident in early childhood and is present throughout life. So it doesn't really fit the model of mental illness. I might be getting too academic there, but there's certainly not a pill that you can take to make autism better. There are a number of treatments to work with some of the aspects of autism to improve them, but nothing is going to take away the autism. I want to mention it quickly, probably in adults more than children, because I think awareness around autism is much better now than it was in the past. But I just wanted to point out that until the 1990s, it was thought that you couldn't have Down syndrome and autism together. So it's pretty recent. So a lot of people won't have autism written on their diagnosis list if they were children before that time. And there's a couple of good books. I'm sorry I don't have them in front of me at the moment, but there's one particular book that I recommend at work that's a really good book summarising Down syndrome and autism, because autism is certainly more common in Down syndrome. The number, I haven't put up numbers because there's such a broad quoted figure, but it is something that everybody is recognising as more of an issue now. There is a separate working group in the Down syndrome, sorry about that background noise, the Down Syndrome Medical Interest Group has a specific work group on autism, and they're producing a lot of resources and doing a lot of work in that space. If we look at how autism presents in someone with Down syndrome, often the changes aren't noticed until a bit older, so more like age 5 to 8, wherein someone who just has autism but doesn't have Down syndrome, it would be at certainly age 2 to 3, but really younger than that, you can notice changes. The key aspects of autism are certainly present, so impaired communication and social skills, but they're often less marked, so less severe than in someone who has autism and doesn't have Down syndrome. There are still clearly issues with interpreting social cues, and there might be issues with eye contact and difficulty in reciprocity, or understanding what someone else is going through and interacting with peers. There's certainly the restricted interests and repetitive behaviours are certainly present. Things like hand flapping, tics and unusual vocalizations and things like that can still occur in Down syndrome. It is more frequent and common. It's really hard to describe this because you can still have some of those things in Down syndrome and not have autism. The sensory issues are present and the behavioural issues are more present. So I guess the most important thing for families here is to know that medical professionals might not think of it, and they might not think of writing it. Of course, in this NDIS age, it's an important thing to think about. So if you are supporting someone that you think might have autism as well as Down syndrome, you might need to prompt their health professional to think about that. If you're looking at the ways of supporting someone, really it's on balance. If you look at all the evidence, what it tells us is that concentrating on the autism and the things that work in autism is going to be most successful for the person who's got Down syndrome and autism. It can be a lonely road for family members who've got someone with Down syndrome and autism, because it's a different set of challenges and needs to someone who's got Down syndrome without autism. So keep that in mind, and I hope you can still hear me. Excellent. I'm going to briefly mention ADHD, which is also sometimes talked about as a mental illness, but really is a neurodevelopmental disorder as well, and is also more common. So the figures say up to 25% of children with autism have ADHD, and it's some of the figures for autism and Down syndrome about 25% as well. You can also have ADHD with Down syndrome without having autism. What you look for, or what might make you think about ADHD, is often a lot of difficulty staying on task, being very talkative, can't sit still, can't stay on a task. As someone gets older, the hyperactivity becomes less prominent, but the poor attention and the impulsivity, which is the fancy word for saying doing silly things, can continue. So ADHD is certainly treatable. There are medication treatments, there are non-medication approaches. So again, it's another thing to think about, and it's another diagnosis that is more likely to be missed in someone with Down syndrome, because you do need to consider what's normal in Down syndrome or not. So also consider that and keep that in mind. Lastly, before we get to the mental health things, I wanted to mention Alzheimer's in Down syndrome. So there's been a lot of research work and a lot of talk, and we know that Alzheimer's disease and dementia is more common in Down syndrome, much more common, and occurs at a younger age in Down syndrome. So it's actually the research out of people with Down syndrome that fueled the amyloid hypothesis, which is all to do with the fact that the gene for amyloid is on chromosome 21, and people with Down syndrome have got 3 of that. Sadly, it turns out to be more complex than that, but there's still ongoing medication trials and things. what's important to understand, and so the teaching, particularly in the 80s and 90s, to particularly doctors, if doctors remember anything about Down syndrome, they remember this dementia thing. And so we know from studies, from postmortem studies, that nearly everybody with Down syndrome will have amyloid deposits in their brain when they're about 35 to 40 years of age. And actually, the more studies they're doing, we know that the amyloid is there even younger. So you can see in this picture, which has got 4 scan pictures, there's someone without Down syndrome on the far left who's age 52. The next one along is a young person with Down syndrome who's age 33, and you can see they've already got more amyloid deposited. That's the yellow stuff in their brain. It's not yellow in real life, it's just the way the scan looks. An older person with Down syndrome has more, and then compared to someone with Alzheimer's disease in the general population or Down syndrome, they have more still. But the important point to make is that it's not all about amyloid. If it was, we'd have much better treatments for dementia by now. And also that clinical dementia is not really evident for a number, 10 to 20 years at least, after these sort of pictures. So the problem, and so we have this graph here that shows you, if you can see the yellow line there that starts at age 40. So at age 40, hardly anyone with Down syndrome has got dementia. If you remember nothing else from today, remember that. The curve then goes up, and it goes up about 20 years earlier than the general population. That's the red. So really, by the time we get to somewhere between 55 and 60, about half of people with Down syndrome at that age will have Alzheimer's. But only 50%, right? So that means 50% don't. And it means that, because I can't tell you how many people we see who are diagnosed by medical professionals, neurologists or psychiatrists usually, sometimes GPs, with dementia at the age of 20. And it's not going to be dementia. It's the short version. It can occur rarely in someone's late 30s. It could start to be more of a consideration in someone's 40s. It is not going to be a consideration when they're 20. Same goes for autism. You don't get autism when you're 25 either, with the normal development beforehand. I start to sound a bit ranty, but I have been doing this for a while in my defense, and it's really damaging, actually. If you are supporting someone who does truly have Alzheimer's and they have Down syndrome, so that person is probably going to be 50-ish. The important message with that is that there are a lot of treatable things that can make someone look like their dementia is worse. And those treatable things include physical causes that I'll mention on the next slide, or mental health causes. So generally talking, and certainly we do a bit of talking in the Down Syndrome Medical Interest Group with the states, the vast majority of people that get referred to, all of us, in America as well as Australia, with a provisional diagnosis of dementia, do not have dementia. They've got something else treatable. It's not to say they might not get dementia further down the track, but it's certainly, it's really important, and it really concerns me how many people are having a severely affected quality of life from that's not necessarily like that. One thing that we do, one thing that can give us a clue to Alzheimer's coming on, is the onset of epilepsy in someone who's over age 40. So epilepsy is more common in Down syndrome, but there's a peak in early childhood and in early 20s, but that's not associated with dementia at all. But if someone who's never had seizures develops seizures over the age of 40, dementia is probably not far off, is what the studies are telling us. So that's a useful thing to keep in mind. Because I think this is my last slide on Alzheimer's in Down syndrome, and a lot of these topics I could talk for a whole hour, so I won't. But the tricky thing is actually being accurate in the diagnosis. We don't have brilliant tools to detect dementia in someone with Down syndrome. The medication treatments that slow the progression of Alzheimer's certainly work in people with Down syndrome, but we've got to try and catch the dementia early enough, and that can be really challenging. So we're still, particularly, there's some really good dementia research groups around the world, particularly Cambridge and Tony Holland's group, and there's other groups in the States as well. One slide on medical problems associated with Down syndrome. So there's a long list. The short version is there's a long list of things that are more common in people with Down syndrome. And not everybody refers to or remembers that list. It's sort of across many parts of the body. When we're talking about someone who's got mental health problems or behavioural problems, the most common causes are sleep apnea, most common medical causes, sleep apnea, undiagnosed celiac disease and thyroid disease, and then constipation and teeth. Those are the most common things. A quick word about celiac disease, which is on that slide, thankfully. There's a couple of things. Celiac disease and sleep apnea are two things that currently doctors will generally go, oh, you don't have any symptoms, we don't need to check for that. But the research really in people with Down syndrome says that that's not true. It really says that we should be checking for those things if someone's presenting with a problem, because it's entirely possible. I've had patients with no gastrointestinal symptoms at all who can have raging celiac disease that's causing them depression or catatonia or terrible skin rashes and no tummy symptoms, because we always think celiac disease is the thing you have to have the gluten-free diet for, right? So in the textbook, the symptoms are bloating and abdominal problems, but you don't have to have those. Similarly, with sleep apnea, there are screening questions that doctors will ask, and they'll say, oh, they're not snoring, they don't need to have a sleep study. The incidence of sleep apnea in people with Down syndrome is very high. And it is one of those things that you might not know is there unless you check for it. So if you are supporting someone with Down syndrome who is having behavioural problems or mental health or anything, and they might be skinny, you don't have to be overweight to have sleep apnea, try and get a sleep study. They are more flexible than they used to be. People also worry about how people with Down syndrome wear masks. I've got patients with Down syndrome who have got a lot of challenges who manage to wear masks, but they are also working on other treatments. So those are a couple of very treatable things that can present as mental health problems. Okay, I'll try and become less ranty as I come into the final little phase. And this is really, I just wanted to talk about symptoms and how some of these mental health conditions present. Broadly, I have to say that the research in this area in Down syndrome really needs a bit of updating. It's fairly old figures and numbers, but I'll acknowledge that as I go through. Certainly broadly, we know that a lot of things are more common in Down syndrome. That's the quick answer. It won't surprise any of you. Some of the information on these slides I've left there purposely because I know some people will look at them later, but I'm not going to read them all. This slide shows you the DSM criteria for depression, and what I wanted to point out is that a lot of people think about depression as being sad, and certainly it can be, but not everybody presents like that. So to actually be diagnosed with depression, you don't have to have looked sad. It can present as withdrawing from things and losing interest in things, which we call anhedonia is the technical word. There can be some other things associated, and changes in sleep and appetite and weight and energy levels are also another way. If your person can't communicate verbally, there are other things that we also look at and think about. We don't know what causes depression, but there are a number of things that seem associated with it. And stress and change and difficulty coping with that is certainly one of them. Physical health problems I've mentioned, and we know that there's some brain changes is probably all I need to say about that. Also, I just wanted to mention treatment of depression is not all just about medication. Things like exercise and and diet. I can't overstate exercise, which I know is a challenge for people with Down syndrome, in part because they've got lower muscle tone and it's a lot more work to do stuff. But exercise is really good for our mental health, so is having good sleep. And so there's a number of other things to think about and concentrate on. Anxiety is also a thing that doesn't come labelled as anxiety. So anxiety is common. It's certainly common in Down syndrome, and it's common in the general population as well. Sometimes anxiety presents as physical symptoms, so being short of breath or having your heart racing. Anxiety or tendencies towards anxiety often start early in life. If it's coming on later in life, you have to think about why is that happening then. These are some of the things, but I've also got a slide about red flags for anxiety, because how do we pick up anxiety when someone's not going to say, I'm really worried about X, Y, Z? And the best way to put it is that an anxious person is often pretty high maintenance. So they are often looking for a lot of reassurance. They're asking things, or they're wanting to know things, and they keep needing to know the same things. And they might ask the same things over and over. They might fly off the handle. They might not like separating from somebody. And they might do some really strange things, like suddenly collapse if a small thing happens. Often that's all tied up with anxiety. Reason to think about that is because some of these behaviours can look pretty odd and strange, and it can be hard to know what to do. So it's good to be able to think that anxiety might be underneath it, because that helps you then progress down the track of what to do about that, depending on the cause. You do also, in someone who has trouble communicating, you do need to remember that sometimes anxiety is there for a reason. And so also think about that. Is there something happening that you haven't found out about? Have they broken an arm and you haven't realised? It could be anything, but just remember that there could be it might not all be in their head. Quick word about obsessive compulsive disorder, which gets diagnosed a lot in Down syndrome, but often and treated with medication. But the thing is that it's true OCD can respond to medication, but if you've just got some rituals or some other things that are causing a lot of problems, that's not true OCD, it won't, and you can end up on an awful lot of drugs for no reason. So that's the reason that slide is there. This is getting really technical. This is the same stuff I teach the psychiatry registrars, but obsessive compulsive disorder in its true self is about having an obsessive thought that you try and get rid of by doing a behaviour like flicking the light switches or washing your hands. It's not being obsessed with something. It's not doing the same thing over and over again, which happens a lot in Down syndrome, but is not going to respond to medication. So those things that I said are normal in Down syndrome, none of them are going to respond to medication. And so that's why it's important to be clear about whether someone's actually got OCD. OCD should only be diagnosed when the thoughts, and those thoughts might be, I'm going to die, or someone's going to die, or something terrible is going to happen. So when someone gets obsessed with that thought, or with the compulsion, so the washing your hands till the skin is red raw. So it is more common. True OCD is more common in Down syndrome, just to make it trickier. This is from Dennis and Brian's book, and they talk about people being in grooves, and it being because what as a psychiatrist I can say is within the realms of normal doesn't mean it's not a problem at home, and doesn't mean that things can't cross over into OCD. Sometimes it's really not very clear territory, but just to think, we're trying to move the things that are maladaptive to become a bit more adaptive, and that's often you need a psychologist to help you figure out what to do there. This little slide is just some things that might help, and I won't read through them all, but they're there if it is if someone's looking back on the slides. I'm going to just talk quickly about what a true hallucination is, because that's what comes up with people's self-talk. A true hallucination sounds just like my voice sounds now to you. It happens outside of someone's head, and it sounds just like there's a person standing there talking to you, or that you can actually see. That's the experience for the person having a true hallucination. So it's not just a voice inside your head. It's not remembering an image of somebody. It's actually for the person, to meet the definition of a true hallucination, it's a real thing that they can see. So that's the key concept, really. That sounds really straightforward, but of course, understanding that in real life can be tricky, and particularly for someone with Down syndrome who can't communicate verbally, and when someone starts saying, have you heard voices, that's really confusing for someone who thinks concretely, and I never use that terminology, but people, if they've been through mental health services, will probably asked that question. So one cause of a hallucination is psychosis, but sometimes it can be an extension of other things happening, and there can be a number of reasons for what's going on. When we try and figure out if it's a true hallucination, I'm interested in what other people feel. So the one thing that's really quite reliable with this is a carer or someone next to somebody will have a very good sense of whether they're seeing or hearing something that's not there. It becomes very obvious to the other person. If they're not getting that sense, then it's probably not a true hallucination. Delusions we see a lot, we don't see so much, but a delusion is a fixed abnormal belief. It's here because it is a psychotic symptom, and it can get confusing with some of the imaginary world. When does that become abnormal? But if you are believing that and some people will be like, oh, you have an imaginary family, imaginary kids, but if you believe that you've got kids that go to a specific state school and you're going to pick them up in the afternoon, that's crossed over into a delusion and psychosis. And that may sound strange for me to say, but I have people going, oh, is that really psychotic? Yes, it's psychotic. If you're trying to pick up someone else's kids and you believe they're yours, you're not in the normal realm of things. Lastly, it is possible to have thought disorder, which is mixed up thoughts as part of psychosis. We really don't see it very commonly, but if someone's speech starts not making sense, that can be part of psychosis, but there's usually also hallucinations or delusions as well. What do we do about it? This is a quick slide. Need to make sure there's not an organic cause. We do, psychosis, if it's true psychosis, does need to be treated with medication to make it get better. Doctors do need to start low and go slow, and really for my people with Down syndrome, they really only need half the normal dose in the general population for psychiatric drugs. It's the only group I say that for. The teaching is that everyone with intellectual disability is like that. It's not really true, but I think people with Down syndrome metabolize these drugs differently. Do reduce pressure, do go slow on them. Lastly, as time is definitely running out, but I'm in the last couple of slides now, so that's good. And we might go a little bit later with questions. I wanted to mention this regression and catatonia, which I've alluded to earlier. The key things to know about this condition are that typically someone has been doing fine and they're doing really well. They're going out to Special Olympics, they're singing, they're dancing, they're doing all the things, they're working. Sometime between age 15 and 25, they withdraw and stop speaking and stop doing things. They suddenly need help getting dressed. They need help showering. They might not speak at all. And it's really dramatic and awful. And you would think that that would be obvious to health professionals, but it's not always. And actually for some families, they only really notice when they look at older videos, particularly if they're supporting someone who was never very verbal to start with. It can be harder to pick that up, but it's really drastic, and it comes on age 10 to 30 the first time. I have seen some people in later life who, if you go back in their history, it's been since then they did really well. They were superstars till they were 18, and then it just all stopped. Probably don't have time to, I'm going to show you a little bit. Let's see if I can turn it down. This is suitably blurry, but the patient who's happy for me to show the video is the guy in the black at the back. And so you can see, look, he's a bit slow, but this is before he had regression. He was out there and doing stuff. I'm going to go into that. And loving it. And that's the other thing with regression, people lose that enjoyment. This is I don't know if this will play. Oh no, it will if I press play. This is just him in the room now. So that guy who could jump around and dance and do all the things now does weird stuff. He holds his hands up in the air. His feet are not, we're just talking. And he will sit like that for long periods of time. So those are some symptoms of catatonia, which needs a whole talk on its own. But I really just wanted to tell people today that it's there and that it exists and that there are treatments. From a psychiatric point of view, I've always felt that there's probably some organic cause to this, which is why we're part of the research and why I looked up the Down syndrome medical interest group in the States. Because as a psychiatrist, you don't want to be giving psychiatric medications and ignoring a physical thing that you could treat and make better. We do, because we still haven't found what that cause is, we do use psychiatric medications to get people better. Very few people recover completely, but they get a lot better. Catatonia is very common with it, and that's the thing that the vast majority of doctors, including psychiatrists and neurologists, don't know much about and don't recognise and don't see and treat. But it is the thing that if it's there and you treat it, someone gets much better. Probably enough said. Also, we need to make sure that people don't have the organic causes and things. So if you think your person has that, you should probably contact our clinic. Lastly, just going to mention this study that we're doing, and we don't know how common that condition is, but our clinic, I've got 10 to 15 patients with that. Some of them are interstate because there's no people interstate interested in this condition really that I've found. They might be there. We are really looking, we really desperately need people with Down syndrome who are well, who are between the age of 18 to 30, who would be able to help us by coming in and filling out some questionnaires. One of them is probably useful with an NDIS application, having a blood test if they can, and having a head scan if they can at the University of Queensland. The reason we need that is because we've got information from the people with this condition, but we've got nothing to compare it to, and apart from the general population. And some of the blood test things, so the autoimmune markers and things like that we're looking at, we think are probably they're probably elevated in people who are well with Down syndrome. So comparing it to the normal population isn't really helpful. So we really need controls. We have a couple, but we need like about another 10. So if you know anybody, please get in touch. These photos, you can see some of our participants who are happy for me to share their photos. We do other research as well. Our Down syndrome clinic is part of an international consortium with Professor Scott Coe at Harvard from our clinic and our clinic research and things. That lets me have meetings at midnight or 1 a.m. on a regular basis, at least monthly, with the States. But there's a lot of things we're doing at that space. We have a mailing list through QSID. So if you would like to be added to the mailing list, email us at that email address and let us know. So to sum up, if you think something is wrong, get it checked out. There are annual health checks that are really good. There is a Medicare item number for people to have an annual health check. There are really good guidelines now on what should be in annual health checks for people with Down syndrome. Broadly with mental health, think about what your person is good at, and when school finishes, think about it before it finishes. Think about how they can have a good life past then, because that point of transition is where lots of things can be really hard and hard to adjust for, even when it goes smoothly. You need to find someone who's going to listen, and that's our number and email address there. And I think that's all. Yes, and that's the details there. So I'll leave that up while we're doing questions.
Fantastic. Thank you, Dr. Cathy. That was that was really informative, and I'm sure a lot of people got a lot from that presentation. We do have a few questions, so I will just start going through them from the top. So when you were talking about the co-occurrence of Down syndrome and autism, you referred to a book that you didn't have in front of you. I just wonder if you could, if you can't pick it up now, drop us at DSQ an email about that book maybe, and then we can include that in an email out to everyone who's on the webinar.
I've got, if I play it from, that's the book there. That's a photo of the book.
No, when you then went on to talk
about the autism one.
Autism,
yes.
yeah,
yes.
You mentioned another
Absolutely.
book.
Yeah, sure,
Awesome.
We'll do.
And just for everyone online, we'll include that in an email that we send out to everyone who's on the webinar after.
Yep.
The next question we had, which has just disappeared off my screen, so bear with me, was, and I think you might have answered this question in some of those last slides around catatonia, but the question was asked when you were talking about Alzheimer's and dementia, as to how that differs from from catatonia. So can you maybe just cover that off quickly?
Well, the biggest difference, so what we find, those people with catatonia and regression are often diagnosed with dementia, and the common points are that someone's presenting with a reduction in their activities of daily living, and they can't dress themselves anymore, and they can't do things, and they seem to not remember things. The real difference is in their age. So if it's regression, it will have come on at age 15 to 25. You can get a very similar picture if someone is 45, and then we're going to be thinking about dementia. But it's really the age that it started is the defining point, really. So there's a lot of other things that are different. Speech being affected prominently is a lot more common with regression that happens in teenagers than with dementia. Yeah.
And you're right, as you touched on, you could do a whole separate webinar on dementia and Down syndrome.
Those things, yes, that's right.
As you could with autism and Down syndrome. And for anyone who is interested, we actually did do a webinar with Griffith Uni on the co-occurrence last year. So that is available on our website, and we are looking to do something more on dementia because it does come up a lot with people's queries. The next question we had was around anxiety and whether dissociation is a symptom of anxiety.
So yes, it can be. So dissociation is I'm thinking how best to describe it in a straightforward way, but dissociation is really that sense of getting off into your own world. You're not losing touch with reality, but you're stepping away from everything else going on outside. And that is really common for anyone who's feeling overwhelmed. And so, yes, anxiety can certainly is probably part of that.
Excellent, thank you. We've got one here that just asked the question about repetitive speech. So you spoke a little bit about A, getting stuck, and B, around self-talk. How about repetitive speech specifically?
Well, repetitive speech can cover a whole lot of different things, and it comes up under a few things. So it depends a little bit if it's the same phrase being said over and over, or if it's in a non-meaningful way or in a meaningful way. So I probably would need more information to be able to answer that. It can pop up in autism, it can pop up in catatonia, but it can also pop up in someone who is anxious and has Down syndrome as well. So it probably depends a bit on the context, I would say.
Yeah, no problem. We had one question asking for a specific recommendation for a GP. I might just ask that person to get in contact with us here at DSQ, and we can, if need be, loop in with yourself, Dr. Cathy, and see if we can help there with someone who would be good. What information should specialists be particularly aware of when assessing someone with Down syndrome for dementia?
Well, really the first, it is difficult to find, and people are often referred to a neurologist around dementia, and there are, but really the diagnosis of dementia in someone with Down syndrome, we focus a lot more on their function and what the test results say. Someone could have really abnormal test results, but actually be not that badly affected. So we really are interested in their function. And what we do suggest as being the absolute most helpful thing would be to be getting hold of one of the screening tools and doing that when someone like turns 40 is the recommendation, to be able to have that baseline, because everybody is different. So there is not one, we can't assume that someone was functioning at this level and then test them and they're down there and know that they were previously up there. So we need to establish the baseline. So when someone's 40, having a look at what their adaptive function is. So it's a lot about what they can and can't do and what their memory and things are. The important thing for medical specialists is really being thorough at excluding anything that could be making it look like dementia or making dementia worse. So excluding any infections, and there's a list of investigations, but sometimes people with Down syndrome just somehow don't get to have all of those tests for various reasons. So looking at all of those things, including sleep apnea and celiac and thyroid and all of those things, really, it's important to exclude those and to not be too caught up with what the scan shows, because the scan is really, it's probably going to be abnormal.
Yeah.
Yeah.
Thank you for that. Couple of questions about, oh, actually one offer, which I think is a great one, and we will make sure we do this through DSQ as well. We'll make sure when we send out details and the recording of this webinar that we include information about your iCard study that you're looking for participants for. So anyone who does want to take up that opportunity can get in contact with you. There's a couple of questions around medication. So one around clarifying what you said about medication doses and starting on those lower doses, and maybe why that starting at that half measure.
I think so. This is something from clinical experience. The teaching in medical school would be that everyone with intellectual disability has a vulnerable brain and you should use lower doses, and I don't argue with that. But I would just really say that for people with Down syndrome, I find it's really quite reliable that, at least for psychiatric medications, that they need a significantly lower dose. And sometimes for some of the people we get, including people with catatonia and things, if they're on the normal dose of something but they're getting side effects, if you reduce the dose, they can be doing much better. And the real problem with psychiatric medications is it can be hard to know if someone's getting side effects. And so it can take more time to start low, and everyone can be impatient about that. But I guess the main message for this group of people is that it is worth starting low and just seeing, because so doctors will say, oh, they didn't need 4 or 6 milligrams of risperidone. It can't have been psychosis if it got better on 0.5. But often it's that sort of thing. And so if 0.5 does the job, why on earth would you want 4 milligrams? That type of thing. Yeah. Makes sense.
Yeah. A couple of questions around how people access your supports and MIDAS, and particularly whether referrals are needed. So maybe if you quickly cover.
So the MIDAS clinic, people can be referred by their GP or a specialist. There's a web link and information on the MADA website, which I find easiest by Googling MIDAS and intellectual disability and MADA, and it comes up there, but there's a referral page and referral guidelines that your GP can read. Essentially, our service is open to anyone age 16 and over who has anyone with Down syndrome, but any other, either having intellectual disability or think they might have intellectual disability. So people don't have to prove it to get in. But yes, age 16 and over, referred by a medical practitioner. And the way it works is that with people's Medicare number is taken, but it's people don't pay. It's a publicly funded service.
Brilliant. In the interest of time, we might just do one last question, which is a good one to cover off on, I think. So an example here of a son who was diagnosed with psychosis when they were 15 and they're now 30. Like, at what point and at what frequency should that kind of diagnosis be reviewed?
Well, I get pretty suspicious about most diagnoses anyway, so I never think a review is a bad idea. So anyone who's on psychiatric medication, that should be reviewed regularly, but I think it never hurts to, in these sorts of situations, it's better to get reviewed than not. And look, someone might come along to clinic and we might go, yes, that's typical for that. Or they might come along and we might go, oh, that sounds more like catatonia than psychosis. That happens. Or that we might go, that sounds like more like catatonia than depression. Because what we see in those situations, people get some of those other symptoms, but if you miss the catatonia thing, so if someone's 15, like, that's making me suspicious already. Yeah. When they're getting those symptoms, if I'm honest with you. Normally psychosis comes on more a little bit older. 18, 20, 25, something like that. So that age, yeah, I would get
worth having that regular review, as you say. Yeah. It's definitely not a set and forget type of diagnosis you'd want to treat. And
also, if people have got psychiatrists or they've got GPs who are interested, they can contact us and we can give them information. Like, they don't have to come and see us. We're very happy to share information, and there are articles, and there's lots of information out there that we can share with people, and we do get GPs and specialists contacting us asking for that sort of thing, and that's a really good sign. Yeah,
it is. That's good. Excellent. Look, we will end the webinar there. Cathy, thank you so much for your time and for sharing your very in-depth knowledge of mental health, but I guess in particularly what is not mental health challenges, which is a very vital part of the picture. I hope everyone on the webinar found that useful. We will be sending out an email probably early next week with a recording and some of those other bits of information. But if you do have any follow-up questions, you've got Dr. Cathy's details there, or contact us here at the office, and we'll be here to support you. So thank you, everybody. Much appreciated.
Thank you.